It's time now for the Q&A section of this lovely morning, and we have some of the questions. You have those in your hand. Thank you so much. She's bringing them to the stage right now. I've got one for Terry Drusey-Smith that we can start off with. Terry, what's it look like when a health clinic or organization uses Bridges to Health?
There are three ways that we use Bridges to Health and Healthcare. One is to build relationships of mutual respect and be more intentional about that, and we are all intentional about that, but this would give you different tools. One of them is institutional change, and we had Ellis Medicine use our work to get people away from using the emergency department as primary care and to reduce unnecessary readmissions. In their case, Schenectady, New York is a Bridges community, so they have a lot of support from their community in order to help people reach health outcomes. I think the one that's been most recently exciting is a dental group in Oregon. And in Oregon, they have integrated healthcare. So you have the providers of dental, oral health, as well as clinical health and mental health working together and surrounding patients with that wraparound, and sometimes even within the same clinic. And what they found was that they looked at the mental model of poverty, and they saw that agency time piece, which is the time that folks in poverty spend, with TANF and with mental health and with the health department and so forth. They call it doing agency time. So that kind of doing agency time was interesting to them. They thought, our outreach should be where people are already. So they actually do a lot of screening with mental health patients who are, so they'll just send a hygienist out there. But the one thing I think that was interesting was that they looked at the hidden rules of oral health in poverty. And in poverty, you don't really expect to keep your teeth. And in middle class, you expect to keep your teeth. And so one of the things they say, another hidden rule was, this child they were screening her at Head Start. She had all these cavities. So, they actually take Child Protective Services with them and do a home visit. And Cindy Shirtcliffe says, we don't usually get past the front door. We're on the porch. And Child Protective Services is there, but never says anything. And Cindy just has a way with people. And she said, we realize that there's a dental fluoride now that can keep you from ever having a cavity, And so she'd say to the parents, do you know your daughter could keep her teeth for her lifetime? Would you be interested to know how she could keep her teeth for her lifetime? If you say that to somebody in a stable, resourced environment, it's a given. It's not necessarily an extra motivation. But when you say that in poverty, someone is attracted to that. And so part of that is understanding that environment and how we do business together and how we listen to one another.
And we have a stack of questions here, great questions that we've got that we're going to get to. And even though some of these questions are directed toward one person on the panel, feel free, any of you, to jump at any time. This one is directed toward Dr. Adams. What policy measures are being taken to address the disparity in health outcomes? Even with the expansion of Medicaid, we still see 2.5 to 3 times infant mortality among minorities. What is in store to close this gap?
Well, that's a wonderful question, and I hope that the person who asked that question heard the challenge that I made to Dr. Werner, because it's tough. And you heard Dr. Gibbons mention earlier how intractable getting rid of these disparities are, but you also heard Anthony talk earlier about the fact that if we don't address these disparities, we're going to pull everyone else down. And we're seeing that happen. And so the answer is, there is no easy answer. It takes everyone in this room. It takes all of us working together. It takes payment changes from FSSA. It takes the State Department of Health going out to communities. And what am I doing? I'm going out to the local health departments. I've been to East Chicago. I've been to Gary. I've been to Allen County. I've been to Scott County. I'm working closely with Dr. Kane with the Marion County Health Department. I want to know what challenges you all face in your community, because as you heard in my talk, what works in Scott County is not what's going to work in and Marion is not what's going to work in Allen. So it's really about finding out your individual challenges. And then the challenge I make to the funders and to the federal funders is give us the flexibility to be able to go out into these communities and work with the communities so that they can tailor their interventions to what their individual needs are. And I think that's how you're going to start to attack some of these health disparities, because the problem is, for number one, people don't acknowledge that there are disparities, and number two, once they do acknowledge them, we've had too many one-size-fits-all solutions that help some groups but don't help other groups. And so again, it's not the panacea, because there is no easy answer, but it's going to take all of us in this room. And I'd love to hear what Dr. Gibbons and Dr. Eaton have to say about that, both as national experts on decreasing health disparities.
Well, the first thing I would say is that there was a slide earlier that was put up. I forget who put it up, but it was a bunch of people sitting around a table and expecting something magical to happen, by not changing. And one of the things we realized working on this problem when I used to run a health department was that we've probably reached the limits of the medical model in terms of trying to reduce infant mortality. Yes. And yet we still keep coming at this sort of as a medical problem. And the fact is, it's beyond a medical problem. This is a social problem manifesting itself in a medical outcome. And so in order to get underneath that, we have to understand kind of the social situatedness of the populations that are manifesting this outcome. And I think Terry spoke to it well about the nature of the kinds of interventions that work in a social setting are very different than the nature of the kind of interventions that work in a medical setting. And so what this requires is kind of a reimagination of how we interface with populations that are at high risk for infant mortality, and who we partner with to try to reduce these outcomes. I think that, unfortunately, there are a lot of brilliant people in healthcare and public health and well-meaning people, but we are incentivized by a payment system which encourages us to treat these problems as individual units of service. And the fact is that to get underneath these problems, they're not, you all know, they're not unique to Indiana. Everywhere you look in this country, looking for infant mortality for populations that have been highly stigmatized over generations, you see this differential, you see this disparity. And so our critical thinking skills force us to think maybe there's something that runs across the board in which we can intervene in a different way. And I think that there are a lot of different approaches. We can talk about them, probably not in the 2 minutes allotted to answer this question. But it's going to require a different kind of public health practice. Mm-hmm. And that's going to require people who pay for public health practice to essentially broaden the constraints under which people can intervene in these problems.
Sure. I would agree with everything Tony has said and others have said. I kind of keep it simple in my mind. I think there are some things that we can do that we need to do better. And that's where there's some effort, particularly inside the healthcare system. But then there are some things that we need to do that we're just not doing now. And we have to start doing some things. Tony has talked about a few, and there are others. And finally, I think that whether you're focusing, my personal view is in line with others, it's going to take fixing a number of things both within and outside of the healthcare system. People rely on more than doctors, nurses, and hospitals to be healthy. It's just the reality of the game. But the system, as Tony said, causes us to look at one side of the coin. And when you look at the reality of it, we have, about 700,000-800,000 docs in this country, about 300,000-400,000 primary care docs who do the bulk of this kind of work. The rest are specialists. We have about 5,800 hospitals and health clinics in the country. But on the other side of the coin, we have 322 million potential people, patients, whatever you want to call them, that are engaged in health for themselves or others and spend about 1% of their lives in front of the healthcare system, it's hard for me to see how we're going to fix any of the problems that we have by maximizing the 1% of the time that they do interact with the system, albeit in an important part of the system. And it's also hard for me to see how 300,000 providers and about 2.6 million nurses can do that to 322 million people rising every second. We add a net person every 12 seconds to this country, unless we get serious about what the potential of technology and networks can do for us.
Carlos, can we let Terry and John jump in? Because I think this is really why we're here. I mean, and you've got a diverse group up here. I'd really love to hear from both of you.
Okay. Well, when you talk about reducing health inequities, for me, it's about changing the environment. And I think that that is directly aligned with the population health research. If you change the environment, then you're going to have a different outcome. So what we're talking about, in my view, is poverty reduction. And listen, the federal government is not going to end poverty anytime soon. I don't know if you've looked at the policies, the poverty policies of the federal government, but it pretty much will keep me where I am, because if I make $100 more a year, I'm going to lose my subsidized housing. If I get my 2-year degree and I make a little bit more money, all of a sudden I'm swimming in the pool called the working poor. And to be honest with you, my life was better at the federal poverty line, because there's a massive amount of people swimming in what I call that aquarium of the working poor. And you've got to get to 200% of that poverty line. So for a family of 4, it's about $24,500 annually as the federal poverty line. Twice that's about $49,000. And even that, for a family of 4, may not be sustainable in some of our communities, and certainly not in San Francisco. So I think that what's happened is communities have had to take on the action of poverty reduction, and you see communities doing that. I mean, the Bay Area states have a big initiative to reduce poverty. Sometimes folks use bridges, but mostly people are using, no matter what model they're using, is the Stanford University Collective Impact Model of collaboration. And they're actually having some success. And I do want to tell you, it can move from grassroots to policy, because in the state of Ohio recently, the legislation was passed to allow $11 million to promote bridges-like communities that have poverty reduction models within the state, because that's going to get people off of welfare. And that, again, is a conservative administration right now. So when you see something hit policy, then you know there's something going on. We have to be more innovative about how we do this. Now, public health is not going to be able to do that alone, but is a huge partner, as well as clinical health, individual health, in those kind of poverty reduction models that we see.
Can I just add something to that? You know, I agree, we have to do something there, but I just think, as Terry was illustrating, it's generally a losing proposition to look for governments to try to reduce poverty. I mean, it doesn't work. It hasn't worked, and waiting for
And it changes with administrations, even if you do get at something that works.
Right, but that doesn't mean we can't do anything. And many people have been lifted out of poverty through opportunities. And so I think, again, for me, this is a perfect example of how broadband can bring opportunities to people and create situations in homes and communities and lives to incentivize new opportunities. I was in Detroit last week in a small part of inner city Detroit called Tech Town, where Dan Gilbert, owner of Quicken Loans and a few NBA basketball teams and other things, is basically buying up the inner city at dollars on pennies on the dollar, and then using it to try to revitalize and incentivize Silicon Valley in Detroit. But he's not just focused on rich white kids from Silicon Valley. He's focused on low income. He's focused on disenfranchised populations. And one thing that he's doing, this is just one idea that I think has some merit, and is far thinking, in a company that he owns called Rocket Fiber. They're laying gigabit fiber in the community, which allows for many things, but they're going into the communities, low-income people, just in the way that we've been talking about. They've been working with community-based organizations at the grassroots level to, one, educate them about the potential that's here, but then also start innovative programs to train individuals about how they can set up their own wireless networks off of the backbone that they're putting in place. You say, oh, that's cool, that's nice, but how that could benefit anybody. If you think about it, though, it's actually powerful. It is the 21st century equivalent of the lemonade stand when you and I grew up, right? That's how you're going to think about new opportunities. That's how you're going to think about new businesses. And that's where when you start learning about that, then you open up a wealth of opportunity to create things and not just be dependent on somebody to give them to you. And I think that's just one way that we can begin to move people and populations out of poverty, and we don't have to sit back and wait for somebody to do it for us.
Dr. Werner, did you want to jump in?
Yeah, I would just add on to Terry's comments because she's exactly right. This is really about social benefit reform. And whether you're talking about the SNAP program or cash assistance or even things like Medicaid, you know, the benefit cliff that you're talking about, and we see this quite frequently in our community where a mom's got a couple kids, she's getting child care benefits and she's getting food stamp benefits as well as health care, and she goes from that $10 an hour to a promotion to $12 to $13 an hour, or maybe some overtime, and then suddenly she loses all those benefits. We're working very hard within the federal guidelines to be able to lift some of those and actually have a graduated benefit structure rather than just lose it all when you get to a certain income level. And I think philosophically what this means is we can't count on the federal government to come up with these type of social welfare or social benefit reforms. I believe, and I think the governor does as well, that it's the state's responsibility to really show what's best for its citizens. And Speaker Ryan, who was really a leader in Congress about how you do this, whether it's disability, voc rehab, any of the social benefits, how can individual states get in a position to be able to have more flexibility in these big federal programs and utilize them more appropriately, including phasing out benefits rather than having folks fall off a cliff and have to make that uncomfortable decision saying, I'd rather not work and stay on benefits than to go out. And that correctional population, I mean, it's a staggering statistic, but when a man comes out of prison and tries to integrate back in his family, he's got to make about $45,000 a year to make up all the social benefits that mom and the family have been drawing. So it's a real disincentive for those families getting back together, and I think that's one of the areas we have to be about, pro-family type of policies to bring those families together, because many of those fathers want to reunite, but once they get in the household, it fundamentally changes household income and kicks them off the cliff.
All right, so we have 2 minutes left. So, you guys have been so great. I just wanted, because I don't want to, go away from something if you want to talk about. We have questions about, HIP 2.0. Has there been any data to show that pregnant women on HIP 2.0 have had better health outcomes? There's a question about tobacco cessation. Why would a doctor say that you shouldn't quit smoking cold turkey because it's, too stressful on the baby? When does the risk of SIDS decrease? I kind of want to just throw that out. Is there anyone who can answer all three of those in 2 minutes? No, no. But is just wrapping up, because I know that we have so many questions to get to. Is there any one of the three that I just talked about that really sticks in your mind where you're like, oh, I really want to talk about that?
Well, I think the practical answer about HIP 2.0, people want to know, and one of the points that I made is that we just unveiled HIP 2.0 earlier this year, but I'm convinced we're going to see outcomes change, not because of the moms, but because of the women who aren't moms yet, who we're getting health care for, and creating a point of contact where they can come in and have that discussion about what it means to be healthy before they get pregnant. Because the horse is already out of the gate once they're in their first trimester and they're getting signed up. The folic acid has already not been taken. The genetic defect, or I'm sorry, the anomalies are already occurring because they didn't take the folic acid. The smoking has already been encountered. All the exposures that happen have already happened. So I think you are going to see changes in outcomes there.
Right, and it's early in the program, as Dr. Adams said, but where we're seeing the shift is where folks are getting care. And the fact that we can, as a state health plan, encourage care to occur at home, at the FQHCs and rural health centers, and this whole idea of no wrong door, where anyone can go in and get basically all their services, including their social benefit, done at one location. That integrated care model is something we've really been trying to incentivize. And in order to do that, you have to be able to pay for primary care, mental health, preventive services, all in the same visit, because logistically it's very difficult for people to get back and forth to the clinic, and we can't have payment policies that make that a challenge for folks. So short of paying for transportation, and we've tried to get CMS to pay for that, they won't do it. In certain circumstances they will, but for routine care, that really is the biggest barrier we see. So when they do get to the clinic, we need to use that time wisely and make sure that they're getting everything they need on that visit.
And
Yeah, I
Carlos,
want to bring
Carlos,
somebody else. Yeah.
well,
it's-
Art, can you come on out real quick? Art Logston is our Assistant Commissioner for Health and Human Services. He's really the mastermind of this whole event. And if you took the time to write a question, then you deserve an answer. So, Art, what is it possible? what I would like for us to do is to take the questions we have submitted, and we can circulate them by email to the speakers, and then do kind of an FAQ and send it out to everybody, so that you all do get an answer to these questions, because they're important, and we wish we had more time, but we don't. I think they're great questions. Is that something we can do, Art?
Yes, sir.
All right. Excellent.